And it's my privilege to talk a little bit about frontline therapy. Now, as Ken mentioned, I have the privilege of serving as the Chief Medical Officer of the International Myeloma Foundation. And in that role, I spend a lot of time in multiple places in the world, mostly the last few years via Zoom. As we said last night, I have more Zoom miles than you can imagine. But I'm very, very sensitive to what Henry just shared with us in terms of access. And I know that in many countries, whether it's here or Australia, as I know Australia is well represented here today, and other places, these American doctors can show up and say, well, I give these 5 drugs together, don't understand why you can't do it down there, and we sort of take this almost arrogant approach of like, we have it and you don't, and thanks for coming out. And as I was joking last night with Simon and others, that we have this term now for these young myeloma physicians in the U.S. that we call myelennials, who have 3 characteristic features. They've never prescribed thalidomide, they've never prescribed oral melphalan, and they think salmon durry is a Sherman-Williams color. And so we've grown a whole breed of physicians that don't have the opportunity and haven't had the opportunity to use all the tools in the toolbox. And I don't say that to just seek praise from you or to pat you on the back, but the clinician strength in so many of these countries where you do have so little is remarkable, how well you use the tools that you have. So in the 3 talks that I'm giving today, I'll have this bit of a dichotomy in the sense that I'll be sharing a little bit of all of the new toys that have made its way into the box so that we can have that sort of really forward-thinking look of what's happening in myeloma. But at the same time, I'll be very cognizant of the fact that I'll be sharing things that you don't have immediate access to. Although some of the principles, which is what I hope to share as we go through, are really common to all. Whether you're using this triplet, that doublet, even a singlet, we hopefully will have common themes. So we're kicking off the day thinking about, and I apologize in advance that you have to listen to me 3 times today. I'm sure there's therapy for that, but if you feel that you need to slip out and get a few cups of coffee or put some other things in your coffee while you're listening, feel free. But I'll have the privilege of sharing with you frontline therapy, relapse therapy, and then we'll have a opportunity at the end of the day today to try and convert me into a bit of a prophet, where I will try and predict what is going to happen in myeloma over the next 5 to 10 years. In the interim, you've got some remarkable speakers that I'm very much looking forward to hearing today. So what do I want to do in the first allotted time that we have is to review the importance of the depth of response in early treatment of myeloma and the increasing use of MRD testing. As I'm going to share in the prophet-like, not to steal my own thunder, talk at the end of the day, it's not all about MRD. There are those who have sort of gone, they have t-shirts made, I heart MRD, MRD forever. But it really isn't just about MRD, although I think we are going to understand how minimal residual disease plays a greater role in what we do. But I've often described myeloma as because I tend to relate to food well, like the Oreo cookie, where there is those patients who have the lowest risk disease and the patients who have the highest risk disease, and the majority of people actually land in the middle of the double stuffed Oreo cookie in the middle. And paradoxically, we often find that people with the lowest risk disease, MRD status is often not as compelling or as informative. Those patients that return, if you will, to an MGUS-like state and still may have a little schmutz of disease that may or may not be important. But in general, we'll talk about MRD testing in its role. And then we'll talk a little bit about both transplant eligible and ineligible patients, and in the eligible population, talk a little bit about what we're doing in quadruplets and then what triplets really currently are the standard of care in transplant ineligible patients. Now, you've all seen a slide like this, and I can turn into Charlie Brown's teacher, wah, 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 and just go on and on about the biology of the disease, but it's a fundamental principle. I always return to the biology for various reasons, but I show this to primarily highlight a few key themes. First of all, that myeloma very often at its diagnosis, not exclusive to high-risk patients, but more common in high-risk patients, there is more than one clone involved. When I had the privilege of being at Mayo Clinic, for which I told Simon this morning I'm still being detoxed, the marvelous decade I spent with Mayo, we tried to do a lot of work in understanding this notion of clonal tiding and clonal evolution. And so understanding that biology is important, because some of those clones that may only be very minor at diagnosis may ultimately, sadly, lead to the succumbing of life and the end of the disease. Secondly, the classic pattern here that as the disease evolves, there is not only a change in the age of the patient, in the comorbidities of the patient, but similarly in the disease biology itself, that it acquires mutations, becomes more chemo-resistant. And so lastly and thirdly, typically what we then see is that with each relapse, there is a shorter time in remission. Now that's not perfect. It's not always correct. I think with the dawn that I'm really looking forward to hearing Simon share with us some of the exciting things that are being done in immunotherapy and bispecific therapies and CAR Ts. And I mean, it's really exciting to see what's happening, and that may change some of this paradigm. But in general, we're seeing with each relapse, there's a shorter time in remission. And so what that means inevitably is that we have to really be careful what we do up front. And sometimes we get very excited about what's available at the very end, but it does become very important what we do up front. The other pragmatic way to look at this is every time we evaluate a study like this, and a more recent one is almost ready for publication that my colleague and good friend Rafael Fonseca has been working on, is that with each line of therapy, there are fewer patients eligible for treatment. Now, it's not down to 1% anymore at fifth line. That number's thicker. But the shape, if you will, of the arrow is still the same. There is still a descending. So this is why I have often joked, saving the best for last is great for a Hallmark movie, but not for myeloma, right? Where we don't want to get into this pattern of saying, I'm going to save this now. Often we have to prove something, as we're going to hear from Simon later, that we have to prove something in that most refractory setting so that it gets its own invitation to the party, as it were, whether it be CAR T-cell or bispecifics or these novel agents, but we want to bring them earlier to have that greater impact. So it's led to this kind of thinking, are you in the cure camp or are you in the control camp of myeloma? So the cure camp says, very American, right? We're going to find them. We're going to get them. We're going to snuff them out. If we can, I'm totally dishing my own country, but I'm a dual citizen, by the way, so I'm still Canadian. You'll hear my Canadianisms every once in a while, and American. But it's this concept of saying, almost which was brilliant in many ways. What Bart Barloghi led out of Arkansas was this total therapy concept of, if I can just give a patient everything I have, I may be able to cure at least a significant fraction. We always debate what fraction he may or may not have cured. And part of the problem at the time is there were more drugs that were very toxic, and some people sadly replaced their disease with another. Their myeloma was cured, but now they have MDS, or they have a debilitating neuropathy, or whatever it may be. But this cure concept is, we can really, almost like diffuse large B-cell lymphoma, if we get that right R-CHOP or bendamustine or tuximab-like combination, we may be able to cure a significant fraction. The control group says, no, myeloma is like hypertension. Let's just give the minimum amount to keep it under control for as long as possible. I think we recognize that both extremes are not particularly correct, but the balance is somewhere in the middle. What I'm going to make the case for is that there has been at least a little tipping of that balance towards the cure side a little bit more, in light of the biology that I just shared, in light of the pragmatism that I've just shared, and in light of the fact that we have now been moving from doublets to triplets, and we've introduced this concept of quadruplets. Now, we have to be careful every time we upgrade, right, in the spirit of all the flights that many of you have experienced, right? I mean, how many upgrades can you get? Like, if you're already in first, where are you going to go, right? You're going to sit in the pilot's seat? And so as we see this improvement, there is a bit of law of diminishing returns, because in many of the triplets we have, we see nearly 90% of people having a response. Now, if you're in the 10%, then your response is 0, right? So we have to be sensitive to that. I don't want to be harsh in that way, but we want to be careful as we add more, because we're adding both clinical and financial toxicity. So how is it that we find that balance? And so we're seeing now, as I'm going to just briefly note, a lot of these quadruplets, we're introducing CD38 antibodies, be it daratumumab or in some jurisdictions, isatuximab, plus the classic proteasome inhibitor and immunomodulatory combination with dexamethasone. I mean, sometimes I think of it as a so-called 1-2 punch, and I don't want to, again, take thunder from my relapse talk later, but what we give patients in first line and in second line, if you almost think of those as a merged phenomenon, like what are those first two things you're going to do, that has a tremendous prognostic influence in the patient. In this notion of what we do early on makes a big difference. So it's not all just about the front line. But now most of these strategies are going to try to employ as many mechanisms of action as possible in a synergistic manner after those first two lines of therapy. And this is why we've been treating people for longer periods of time with maintenance therapy that we'll come to a little bit later. And even the relatively recent Stamina study that you may be familiar with, this is a trial where everyone received a single transplant and then were randomized to get a second transplant, then lenalidomide maintenance, have more consolidation than lenalidomide maintenance, or just go straight to lenalidomide maintenance. And there really was not a big difference between the three arms. But in longer term follow-up, although not perfectly powered to do so, there was a clause after roughly 3 years of lenalidomide maintenance, patients had a choice to come off or to continue, not based on toxicity, that was a whole separate phenomenon, but just by sheer choice. You've been on this for 3.5 years now, do we want to stop or do we want to continue? And those who remained on had a better outcome. So we haven't quite had that magic of being able to stop therapy, although I'm going to speak extensively today about the whole notion of stopping therapy, because that's my favorite drug in myeloma. No disrespect to any drug maker here, but I say that to my patients. My favorite drug is nada, nothing, rien, right? Because patients really like it, right? It's the best cost, it's really well tolerated, compliance is particularly good. Right, again, I'm being a little facetious, but the point is this idea that, we look at our patients and say, you'll take it and you'll like it forever, is really not what any of us want to do as clinicians, as we care for our patients. And then we'll talk a bit more about the immunotherapy concept. So why do I say all of this as well? The depth of response matters. We've been able to demonstrate this not only theoretically, but pragmatically through clinical trials. So the deeper one's response, although it's not a perfect correlation, I mean, I draw this for every patient that comes in my clinic, a big whiteboard in my consultation room. Over 85% of us identify as visual learners. So I like to map things out for patients and draw them out for them. And I always talk about the 2 Ds of response, depth and duration. And they're not perfectly correlated, but generally speaking, depth correlates to duration. The extremes of the Oreo cookie are where we have challenges with this, where paradoxically, people with the highest risk disease can often be very responsive initially and then relapse quickly. Now that's perhaps the worst situation in myeloma, right? And then the other paradox is that in the lowest risk of patients, there's some patients that never get that real depth, but end up having a very durable response because they're left with that little bit of MGUS behind, right? So is it better to have had a deep remission and lose it than to have never had it at all, right? Is it better to have loved and lost love than to have never loved at all, right? It's a little personal, right? But I'm a newlywed, by the way. Today's my 6-month anniversary, so I know I'm going to totally nauseate you by the end of the day. But if you give me talking about Emily, oh my goodness, it's more exciting than MRD, that's for sure. But the notion is there that there is this paradox, so we can't always correlate depth to duration, but in a general principle, those two things are correlated, and we've demonstrated that in multiple ways. Perhaps the most striking one to me was a group of Spanish studies, frontline therapy, that were merged together for this analysis, where they looked at the outcome based on response. Now, the Canadian statistician in me starts to have hives and maybe even seizures when I see people draw PFS curves based on response, because that's not really kosher. But it is when you're trying to evaluate this concept, which is to say, does the depth of response in a similar cohort of patients make a difference? And what's not shocking here is, first of all, you may see in the red lines that those patients that did not have a very good response did not have a very, very good outcome. No surprise. On the other extreme, the patients that had the deepest MRD negativity response in the green line did the very best. Again, not shocking. But what was perhaps shocking in this study were 2 things. One, how significantly different the MRD negative patients were from those who achieved CR. Because you would have expected maybe the CR line to be a bit closer to the green line. And secondly, that whether you had a PR, a near CR, or a CR, essentially your outcome was the same. So you look at that patient clinic who's had a 60% response rate, or a 60% drop in their monoclonal protein, and the person next to them has a 99% drop in their monoclonal protein. You think, well, one of these things is not like the other. Well, actually, their total outcome may be very, very similar. So really where the magic is getting them into that MRD negativity. So as we think about transplant-eligible patients, there's so many things, and I'm very cognizant of the fact when we have a day like this, there's a lot of talks, and I joked earlier about Charlie Brown's teacher that I don't want to be wah, 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 and I just don't want load data on you. I'm going to try and just pull a couple of slides from these studies to make a point, right? As I try and teach our residents and fellows, you know, conferences like this are not remedial reading courses, right? You don't want people just to be reading your slides all day long. You hopefully brought me here to give a bit of an interpretive concept behind these studies. But there are some very key studies that I think influence what is happening now in frontline therapy, which include those that determine whether or not there's still a role of transplant, whether or not we need a fourth drug, whether or not we need longer induction therapy, and whether or not we can stop based on MRD status. So these four groupings that I have here are looking to answer those four questions. And of course, one of the most important questions is to transplant or not to transplant. And there have been a whole series of studies that have looked at this. Most recently, two very important studies. The French study that compared giving RVD versus RVD plus transplant, and notably gave only a year of maintenance therapy thereafter, demonstrated over a year of improvement in progression-free survival for the transplant arm, but ultimately no difference in overall survival. And you interpret this in one of two ways: if you're a transplanter or if you're not a transplanter, which in the US is like, are you a Democrat or are you a Republican, right? Like, they really don't talk very well to each other. So if you're a transplanter, you know, you're going to say, do you see that year's benefit? Like, who doesn't want the year of improvement? If you're a non-transplanter, you're going to say, well, it really doesn't make a difference. If you're a transplanter, you're going to say, well, you know, 79% of the non-transplant group at first relapse got a transplant. So really, this is not, I'm not sure it's advancing itself here. Apparently the computer knows that I'm going too slowly. This is really not a transplant versus no transplant. This is, do transplant up front or do it at first relapse. So if only we had a study that didn't have a significant fraction of patients at first relapse who had a transplant. Now you're all on the edge of your seat wanting to see what that study is, am I right? Right? Yeah, that's the determination trial. So the determination trial was just presented at ASCO. I had the privilege of being the discussant. If you're not familiar with ASCO, 4 abstracts are selected from all of the boring solid tumors, as well as heme malignancies for publication, so for presentation. So we rarely get a myeloma one in there, but we did this year. And I had the privilege of being the discussant, which means I had to give a talk to 10,000 people, which you don't get to do every day. I'd rather give a talk to 30 people in Queenstown. Let me tell you that. Okay, I'm sucking up a little, but it's working. So, and so this study was evaluated. Very similar design, RVD plus transplant versus RVD. One notable difference was that patients received lenalidomide maintenance until progression. The other notable difference is that this study happened in Merca, right? Not in France, as in the first study, where in this situation, less than 25% of patients at first relapse went on to transplant. So this is more of a true isolating effect of transplant. Well, what did it demonstrate? Well, here it demonstrated a 21-month improvement in progression-free survival, which before my talk I was reminded of by several transplanters across the country. Right? Just to know, Joe, did you notice? Well, yes, I did notice the curve. Right? And they wanted to really trumpet this notion that there was this 21-month improvement in PFS, but very similar to the study I just showed you, no difference in overall survival. So it raised a lot of questions, and there's so many things we could say. I did, as I mentioned, the presentation, I sort of narrowed it down to this one slide to share with you that transplant still has a role. It's like any other treatment. If I told you I have a treatment that improves progression-free survival by 21 months, right? Just don't call it transplant. Call it like transplantamide or transplantamab or transplantamib, you know? Then you might not see it in the same light that it has a benefit. But it may not be mandatory to say you'll take it and you like it right at the start. It may not be necessary to always, so I made this sort of joke about a prefix menu where you go in and you have to have this appetizer and then you must have this main course, you may have dessert, to have a more flexible menu. Say, no, I want dessert first. You know, some people show up late at a restaurant and all they do is they eat dessert first. And I won't mention Simon by name, but sometimes that happens. And yet we also did see, which we can't deny, is that transplant clearly came with greater toxicity, both short-term and long-term. Interestingly, the second primary malignancy differences were not that significant overall, but significantly more heme malignancy toxicity, namely myelodysplasia, in the transplant arm. And then, of course, we did learn about maintenance therapy through this, that the average dose of maintenance therapy was lower in the transplant group than in the non-transplant group. And so I think one of the things we have to do when we have the opportunity to use lenalidomide maintenance is to dose appropriately, to, again, not set artificial doses for patients, but to manage that with them so that we can minimize their toxicity. Because it's one thing to say, look, you're going to be sick for 3 months for transplant. It's another thing to say, I'm going to put you on maintenance therapy for 5 years, and you're going to have diarrhea for 5 years. I mean, that's not good. We can manage that in the majority of patients if we dose appropriately with the right supportive care. So then the question comes, okay, great. We have a good triplet. We've got transplant. It still has a role. No matter what you think about the progression-free versus overall survival differences in those first two studies, patients do really well with frontline therapy. They're already been upgraded to business class, let's say, from where they had been before. Can we upgrade them to first? Is there something that we can do better by adding a fourth drug? And we have a few studies that guide that. The first of which, as you likely know, is the Griffin study, which really introduced three concepts. One, we would give 4 drugs now instead of 3. So add daratumumab at the very start. Secondly, give 2 cycles of consolidation post-transplant, which is not really a consensus anywhere. I always say, if I put 10 myeloma doctors, one of the roles I have at the IMF is I often bring myeloma experts together for the IMWG to discuss things. And I joke about it, but it's pretty true. If I put 10 myeloma doctors in the room, I got 12 opinions. Like, really. It's hard to find consensus on anything, right? It's a miracle that we have consensus guidelines. And yet, it did introduce this notion. So number 1, of 4 drugs instead of 3, giving 2 months of consolidation, and then giving 2 years of daratumumab maintenance alongside of lenalidomide. So lenalidomide maintenance is given in both, but the question here is, can we give 2 years of dara? So not indefinite dara, not short-term dara, but they're trying to find that sweet spot with 2 years. And so ultimately, as we learned through the study, is that with each step, there was a deepening of response. Now, part of this is a bit artificial to where the response was captured, but I was actually struck in this. If you look at the middle bar that says end of consolidation, that there was a deepening of response by those 2 extra cycles post-transplant. Now, some of that was because the response hadn't been captured immediately after transplant. It was only captured after consolidation. But that number, whether if you look in the purple bars going from 21 to 42 of the deepest response, or in the orange bars from 14 to 32, that tells us that there may be sensitive disease that we can overcome right after a transplant. And furthermore, it was yet deepened even more during the maintenance phase. So it's not only what we do in those first few months. You remember that why do we give 4 months? If you're a millennial, you'd never know this, but why do we give 4 months of induction therapy? I mean, it pretty much harps back to the days of giving VAD, when we didn't want to give more than 4 months of adriamycin for the cardiac toxicity. There's no carved in stone tablet from the Lord telling us that we need to give 4 months of induction. So this does speak to the potential, which will be our next point in a moment, about longer induction strategies. And not only did this reflect in overall response, it reflected in depth of response, getting to my earlier point about MRD negativity, where we have over a doubling of MRD negativity later on. Now, this translated to an early trend of improvement in progression-free survival, but not a difference yet in overall survival. Well, the other CD38 agent that I had the privilege of helping develop back in the day was isatuximab, and so the German study group decided to take this a little bit further, that they did longer induction cycles, so 6-week cycles, but did 3 of them prior to transplant. And the reason why I also wanted to include this study is that this study was the first frontline study to choose their primary endpoint of MRD negativity. So not just response rate or progression-free survival, but indeed their depth of response in terms of MRD negativity. And with just 3 cycles prior to transplant, half of the patients in the ISA VRD arm achieved MRD negativity. So we've not seen that level of depth of response prior to transplant. So again, now they collected enough cells to go to, as Harmut, when he presented this, very sharply said, enough for 2 autografts. And I'm like, okay, all right. So they're thinking about doing potentially up to 2 transplants in these patients, but we see already that there is this deepening of response with quadruplets. I can't tell you I'm totally sold on quadruplets yet, but it's giving us an intriguing point. So hopefully I presented the case that 4 appears to be better than 3, but how long do we do this? Now, if I had time and go into the details of another 4-drug study, the Cassiopeia study, we could look at some of the challenges there of knowing really how long we have to give all 4. Because again, I'm a fan of de-escalating therapy at the right time. But this study, the Forte study, looked at something slightly different, where now it was saying, well, we're not really married to the 4 months, are we? Why don't we give a year of induction treatment, or 8 months plus a transplant? And then there was the third arm with the KCD in yellow that I won't, for time's sake, address today. And then there was a second randomization of saying, should we just give lenalidomide maintenance, or can we make it better with KR? So a little bit like the Griffin study, where it was DR, now here it's KR, and now they're both given until progression. So not just 2 years of K. So this trial is not as mature as the other, but it has read out. And the first observation that is unique to this study, I would suggest, in light of what I just shared, was if we ignore the first set of bars for a moment, not to ignore the third arm per se, but KCD was ultimately shown to be inferior, but the depth of response between 8 months of, in this case, now given with KRD, so carfilzomib, lenalidomide, and dexamethasone, or 8 months of KRD plus a transplant, they had the same depth of response. So if you're a transplanter, you're sweating bullets here. You're like, maybe they don't need me. Maybe I don't have a role. Maybe we should change our name from the American Society of Bone Marrow Transplant to the American Society of Cellular Therapy. Oh, they did that already. To make sure that they are still relevant. No, I'm not. I'm a transplanter too, so I'm not picking on anyone. I'm just saying that this was an initial concern, but interestingly, there was a difference in progression-free survival. So that law that I shared with you earlier, that depth correlates to duration, doesn't always hold. You know, we used to tell patients, we still do that, you know, transplant contributes to the depth and the duration of response. So even in someone who's already achieved a CR, and potentially even MRD negativity before a transplant, we still do a transplant. And this may be justification for it, because the PFS benefit in that blue curve, which is the KRD plus transplant, was significantly better than the green curve, which was the KRD alone. Interestingly, there was also early benefit of giving 2-drug maintenance therapy versus 1, which, you know, in principle, the more you give, the better you do, but this was a kind of a unique concept. I don't have time to go through it, but interestingly, in that study, even those patients with standard and high-risk disease did better with KR maintenance versus R maintenance. As we always associate dual maintenance with high risk, but maybe even with standard risk, it may be a future consideration. And then the other last principle that I want to share with us is, can we stop, right? In the words of one of my patients last week, enough already. You know, like, can we stop this already? You know? And so there is a point where we want to stop. And so Luciano Costa led the master trial, which was really, I think, brilliant in its concept of saying, let's take a quadruplet, and this time DARA KRD, arguably the most potent, at least upfront therapy that we can provide, give it to them, give them a transplant, give them consolidation, but at each of these steps you see along the way, checking their MRD status and seeing if, when someone has confirmed second MRD negativity, that we can actually stop therapy. And the bottom line here, which I'll take you to, this was that there was obviously a deepening of response with each time, such that 98% of patients achieved a VGPR or greater. But interestingly, those patients that had one high-risk cytogenetic abnormality did not really differ from those who had no high-risk cytogenetic abnormalities, and they seemed to do quite well with this program. Meaning, even though their drugs were stopped, they're relatively flat lines here of yellow and green. But those patients who were higher risk, that had more than one cytogenetic abnormality, the more uber risk or ultra high risk, or whatever phrase you prefer, this strategy did not seem to work for them. There is clearly a subset of patients where stopping on the basis of MRD negativity alone is not appropriate. And so we need to think a little bit how to deal with those patients. And again, it's always a balance, right? I don't want to undertreat the standard risk, but I also want to make sure I don't overtreat them. I don't want to undertreat ultra high risk or overtreat them. But we know that high risk patients have more horsepower, right? Their disease has a preponderance to grow back more quickly. And maybe in those patients, as I'm going to suggest in my final talk today, maybe we take a different strategy with them, where we look at MRD, but we also look at other features that may determine whether or not we can stop. So this simple, oh, you've reached a depth of response, we can stop therapy, may work in some patients, but clearly doesn't work in all. But I think it is opening the door, and I think, thankfully now, a lot of larger prospective clinical trials are being designed with the same venue, where they say, oh, you've achieved MRD negativity, and even better, you've achieved MRD negativity twice, like it's been confirmed, at least 6 months apart. Now let's randomize you to nada versus something, and see if it does make a difference in the longer term. So how do I conclude? Well, I do think that when available in places like the US, and now it's listed in our NCCN guidelines, so if you're not very familiar with the US system, not that I want to bore you with it, we have the FDA that approves drugs that formally have their indication, but then there's another group of experts that meet together and give what are called the NCCN guidelines, and those guidelines don't necessarily reflect what's fully approved. We've recently had quadruplets added to the NCCN guidelines. We actually did have approval of DVTD, although we don't use a lot of thalidomide in the US. And so I think we are seeing this transition where people are going to be giving quadruplets, but there is still a very important question around for how long. Not only which one, DARA versus ESA, although we've been using a lot more DARA just because of its earlier release, but what is the optimal length of that quadruplet? When can you de-escalate? Is it after consolidation? Is it during maintenance? As we see more from not only the Griffin study, but from a couple other studies I didn't have time to mention, larger phase 3 studies, I think we'll understand this situation a little bit better. Transplant still has a role. It is still a very valuable modality and it can work. I didn't get into it in detail, but interestingly, both the IFM and the determination studies cut off age at 65. And so how applicable that is to your 70, 75, or 78-year-old patient is worthy of discussion. But nonetheless, it still has a role. And MRD-guided discontinuation may be possible in lower risk patients, but we still have this concern about the quick relapse of patients who are higher risk. And maybe with time, we'll have a better way to even improve maintenance therapy and possibly add other agents, be it daratumumab or carfilzomib. And the last little bit that I have, and I want to keep us early if not absolutely on time, is to think a little bit about what about the transplant ineligible patient. And so we are just about to do our second iteration of the ASCO guidelines. And one of the things that we address in those guidelines is who is eligible for transplant. Now that the two treatments are so similar, that we see these triplet-like approaches that are very similar in both transplant eligible and ineligible, the selection of transplant eligibility is important and doesn't necessarily have to be done right off the bat. You could wait to see how people do with their initial triplet. That being said, chronological age by itself should not be the cutoff, right? So finally in myeloma, we're catching up to some of our other solid tumor colleagues with respect to geriatric oncology and appropriate geriatric assessment. I mean, we've historically not been very good at it. Oh, the patient was able to walk into the room by themselves, therefore they passed the, myeloma geriatric assessment. It's not that simple anymore, and I think we have to get more sophisticated. And there's some of my mentees who have dedicated now their whole careers to, some of them have actually done dual fellowships in geriatrics and in hematology oncology so that they can be the ones that guide us through this. And I would suggest to you that geriatric oncology actually is a very strong and emerging field that we're going to see much more of. Well, there are lots of studies that have been done. For time's sake, I'm just going to talk about really two of them. The SWOG study, one because it really set the standard of care for a long time, and it was also run by my boss, Brian Dury. The SWOG study, which compared giving VRD to RD, and then more recently the MAIA study, giving DARA RD versus RD, and I'll talk a little bit about these numbers in just a moment. But I did, go back to the slide, that did notice that there was a significant difference in the population. The average age in the SWOG was 63. Average age in MAIA was 73. So it is a little bit unfair to some degree to compare apples and oranges here. But in the MAIA study, we saw in this older, perhaps more reflective of the transplant ineligible patients, the strategy of giving DRD versus giving RD. Why is this so much different than the SWOG study? In the SWOG study with the bortezomib, it was given for a fixed duration. Here you have two novel agents, if you will, given continuously. And on this spirit of what we said before of longer therapies, it follows that. And so I think this was relatively reflective of the real myeloma population, with the average age of diagnosis of myeloma in the US being around 70. And we saw an improvement in response rate. It got an upgrade here about 10 to 12%. Perhaps more importantly was the difference in progression-free survival. So at 5 years, we see that a little over half of patients in the DRD arm are still in remission, whereas a little under 30% with a 34-month PFS in those that only had RD, and this actually translated to an overall survival benefit. So even if you don't compare the difference between those two, to tell a patient now, well, average age 73, transplant's ineligible, that with one course of therapy, 2/3 of patients are still alive at 5 years. That's not what we were saying in the early days of myeloma. You know, I've had the privilege of being involved in myeloma now for about 25 years, and when I started, I wanted to do myeloma because I wanted to treat the sickest of the sick. You remember what myeloma clinics were like then? Most patients came in back braces. We didn't even have bisphosphonates yet. The average survival was maybe 1 to 2 years. So to say to people with one type of therapy, I can have 2/3 of people alive at 5 years is still important. Now granted, that's still a third of people not with us, and that's not acceptable either. So obviously we want to make that much better. So although transplant remains the standard of care, I'm going to make a case a little bit later that I think in a population, again, I don't want to be ageist, but in that 65 to 75 age realm, we have to be particularly careful in selecting those patients for transplant because of the toxicity on the one hand, but on the other hand, because of how well they can do without a transplant. Right? Seeing that these patients can do well with a Myel-like regimen is important, and continuous therapies resulted in better outcomes. And the balance of efficacy and toxicity is so important in this population. I mentioned it earlier in the context of maintenance therapy, but let me very much emphasize it here. I've kind of joked with, I have a nurse practitioner who worked with me in the clinic, Susie. She is fantastic. I've worked with hundreds of advanced practitioners in my years, and Susie is just absolutely remarkable. She's both brilliant and compassionate. And I joke sometimes walking into clinic singing the song, "I can't live if living is without you." And so we joke. She and her family become very close friends to us. And I've joked with Susie very often, I want to change the name of my clinic from the Myeloma Clinic to the dexamethasone reduction service, because I am constantly telling people, like, don't do it, stop it, you know, like in the words of Gandhi, don't fight, like don't fight the dexamethasone. So I draw this picture for patients, and I have a slide that I sometimes show, I don't think I put it here, where I show the shuttle with the booster rockets on the side of it. Think of dexamethasone as the booster rockets, like really helpful for the first few cycles. But then let's bring it down, shall we? And we now actually have evidence. You know, there's a very good Italian study that had looked at giving RD continuously versus RD with fixed dex. And actually the outcomes were better in those people that had stopped the dex, which shouldn't be surprising to us. In the earliest of, for those who can remember, the ECOG study of giving lenalidomide versus high-dose dex, lenalidomide versus low-dose dex. Initially, in the first 6 months, we thought, ooh, the high-dose dex people are doing a little bit better. Mortality was worse at 1 year because dex causes issues. And when you're evaluating dex with your patient, you know, you need to talk to them about their energy level, their sleep patterns, their appetite, and then have a chat with their spouse too. Because they're usually the ones who are like, enough already. You know, like, can you please stop their dexamethasone? They become someone else, like a Jekyll and Hyde kind of situation. So I think I'm very careful that in most of my transplant ineligible patients, by the 6-month mark, I want them off steroids. Typically use whatever dose I'm going to plan to start with, be it 20 or 40, typically 20 in this population, for at least the first 2 months, and then a taper down so that by 6 they're pretty much off of it. So with these two choices of VRD and DRD, they're both very good choices. I tend to favor DRD because I find it a little bit more tolerable in patients. The bortezomib-induced neuropathy obviously is not present. But by the way, when I do use VRD, I can't say I use it the way it was used in SWOG. I typically will use it only weekly. In fact, I almost only use bortezomib ever weekly. And in that population, I plan to give it to them weekly for 6 months. And if they don't have neuropathy, I'll then give it to them every other week for the next 6 months. And I found that to be a bit of a sweet spot. Now this is the art of myeloma, right? This is myeloma 202, not just 101. This is going from good to great, and hopefully we can do more of that. And then ultimately, who knows? I mean, it's a bit too early to say, but we do have studies ongoing now looking at the quadruplets in that group as well. So the evolution of myeloma therapy is remarkable. I'm only hitting the first bar here. We have a lot more to come the rest of the day, but it is really remarkable what we've had in black and red for many years, what in green we've more recently added, and what in purple on the bottom we may be adding in the days and years to come. We've really expanded the toolbox, haven't we? And I think we have to be strategic not only in using them at rescue, but in using them in frontline therapy. And I will stop there, and thank you very much for your attention. So I think we're a little ahead of schedule, which is good, but I don't know if, do we want to do any Sarah, are we doing any Q&A now, or are we going to save that for a little bit later? Right.
Why don't we see what Henry's doing?
Right. Henry, guide us, lead us.
Thank you, Joe. That was an amazing talk. I hope you can hear me.
Yes,
I'll keep talking for now. Yeah,
Yep.
good. So yeah, I think the MRD data is very interesting, and just wondering is, we are getting into the realm of stopping treatment based on people who got sustained MRD negativity. Is there any trials that's planning or being planned where, once the patient lose their MRD, they get started back on treatment?
There are a few studies that are evaluated. So some of those same studies that are looking at randomizing people when they become MRD negative, in the placebo arm, if you will, there are some of them that are accounting for saying, if you're on NADA, but then your disease flips from MRD negative to positive, should we do something? And it's a very good question. So yes, we're evaluating it. No, we don't know what it means yet. In our IMWG criteria for relapse, that is not considered relapse, as you likely know, right? So going from MRD negative to MRD positive does not meet criteria for an IMWG relapse, right? So for a relapse with measurable monoclonal protein, someone has to have 25% rise, which obviously in MRD negativity is not an issue, but they have to have an absolute rise of an M spike of 0.5 grams per deciliter or in light chains of 10. I think you're asking a really important question. And it's really twofold down the line, which is to say, okay, I was MRD negative, I flipped to positive. Do I A, wait and watch? Do I B, reintroduce what I was on because it was keeping me there before? Or do I C, take a different approach with a different therapy? And Henry, I just don't know if we know the answer to that yet. I suspect part of that with time we'll have a better understanding. I'm going to add one more last layer of wrinkle to your question and say, that based on what we showed with the master study, I bet you that question is even more complicated if you throw in the variable of risk status, meaning the high-risk patient may behave differently than the standard risk patient. And so it's going to take a long time to collect that information. But I think that's why I always try to couch it in saying, yes, MRD is a valuable goal, but it is not MRD or bust. You can't only look at MRD status because, as I tell every patient, myeloma is a crime scene, right? And you can't make your determination based on one piece of the crime scene. You need the whole thing. Maybe because my mother is a pathologist and she's obsessed with shows like CSI, and maybe that's influenced me a little bit, but this notion of having to look at the whole picture.
Thank you, Joe. And I don't see any questions on Zoom or Facebook, so we can open the phone to those who are there in the conference room.
Any questions or corrections? Professor Harrison. Oh, there's one here too.
Joe, when we think about response, we think about using paraprotein and light chain as the main determining thing of response, which is actually a byproduct of the tumor. And it takes a long time for that response to evolve because of the decay factor. And one of the things that we notice with some of the newer therapies, you're getting a response within weeks of initiating your therapy. When do you think we'll reevaluate how we determine response in myeloma and move away from biochemical, relatively insensitive tools and use more direct measurements of the tumor mass, which is going to be more difficult to do, but ultimately is actually what we want to do. Look at what the tumor is doing, not what the biochemical product of the tumor is.
Yeah, no, that's a great question that you ask, Simon, and I don't know if anyone has a perfect answer to it. I would look at it this way. Going back to this crime scene notion, is that we have to remember that the biochemical measurement, not only can it be delayed, it's not always accurate, right? Why look at the smoke if you can look at the gun, right? So the question is, do we have a better measure of the smoke, which I'm going to suggest in the future will be mass spec, because mass spec is a much more sensitive tool. Down to the Dalton, it can measure your monoclonal protein, and it can discriminate it from others. You can see, is it the same monoclonal protein we had before? Is it just background noise from the daratumab or rituximab that they're on? So I think that's probably step one. But we did make a bit of a move in the IMWG criteria to start adding imaging as part of response, and even MRD negativity, not allowing us to just, we actually have a manuscript we've just submitted from the experience at Princess Margaret in Toronto and in Mayo Clinic in Arizona, of this discordance between people who are MRD negative biochemically, but still persistently positive on PET scanning, because it's that complexity of it. And so I think your question raises a really important point, that if we only hang our hat on the biochemical response, we're going to be disappointed both in accuracy and in timing. And so we need to be able to do it more sophisticated. How is it we're going to be able to do it? Imaging may be part of that solution. I think circulating tumor cells will be part of that solution. I think we're getting much better at being able to detect them, and I think that's going to come up a little bit in the discussion today. A little bit unlike our solid tumor colleagues that are looking for a lot of ctDNA, we may be able to more accurately capture even the minute number of plasma cells that may be left circulating after. Because it would be nice to not only have it a better measure of the tumor burden, but not always to be doing it by virtue of marrow, which is why we've historically done the biochemical one. So I'd be interested with time in your thoughts on this, but I think the stepwise fashion that we're getting there is better biochemical measures, incorporating imaging measures, developing a better true biological measure of the disease itself.
Yeah, I mean, I would agree. I think that PET MRD is probably the kind of beginnings of that thought process. But I think the tools, in a very similar way that when we started having effective therapy in CML, we need to improve the tools to measure the disease. And the same thing is happening in myeloma. We just haven't quite nailed it yet.
Absolutely. Other questions? I think there was, no? Okay.
Can I ask a question? Can you hear me?
Yes, we can hear you. Please do.
Oh, thank you.
You're
Yeah,
the
great
boss.
talk, Joe. That was very, very comprehensive. I guess this is just a slightly simple one, and you have touched on it in your treatment of the older patient. But for example, in your clinic, if you haven't got people on a trial in the transplant eligible group, and we know that around 20 to 25% of patients are considered high risk because of adverse cytogenetics like T414. Do you treat that? Do you pick them out and treat them differently and give them extra treatment, like start with quadruplet? What do you do practically for that? The high risk group.
Great question. So I do two things. I have a conversation with them about how, although VRD seems to perform well with high risk patients in general, that there is a feeling in the myeloma community that we could either change that to KRD, including carfilzomib, or going to a quadruplet of DVRD. It's not as easy to give DKRD yet. So I discuss those as the three key options for them, and I tend to favor using more than just VRD, meaning either KRD or DVRD. And part of that is guided by, are there other features that, any particular risk of neuropathy or something like that, if a patient has diabetes and so on, where I'll try and go to the KRD approach. But it's interesting because we have different institutions, like in Emory and others, that will choose a KRD or a DVRD approach in the high-risk patients. But the second thing that I do that may be even more important is I'm particularly sensitive to their depth of response. Whereas in the standard risk patient, I'm a little bit more patient. I'm willing to take them to transplant if they don't have, a particularly deep response, because I know I've got time after the transplant to modify more if I need to. But in that high-risk patient, if after the first few cycles I'm really not seeing a depth of response, I'm willing to make an adjustment, which is if they're on a triplet, adding a fourth drug, or if they've been on bortezomib, switching that to carfilzomib, because we've all been burned by some of those patients, of which I had one recently, just primary refractory disease, which is a whole separate topic in and of itself. But I know the horsepower of high risk, and I want to be particularly careful The last point, Ken, would be that although I can lump high risk together, I particularly get nervous about the uber high risks. And in those, I may be pushing more for the quadruplet. And what I mean by that are people that have two veritable high-risk features. Like I just saw a patient last week who has an amplification of 1Q and translocation 414. That person makes me very nervous, and I want to come at that at every angle. I don't think we fully answered the question of 1Q in general. If someone has just 3 copies of 1Q, it does seem to be at least somewhat of a high-risk phenomenon, but not as high risk as those that have 4 or more copies by the amplification. So in summary, I tend to try and explore the other 2 options of either switching it from VRD to KRD or adding D to give it DVRD. And secondly, I'm very cautious in watching their response and will make an adjustment if they're not coming down nicely.
Thank you.
Thank you, Ken. Okay, I'll turn it to whoever's next. Thank you.